Dear friends, in continuation with the quality and ethics issues pertaining to critical care, I will be talking about a very important and pertinent topic, that is breaking bad news. And oftentimes we find we lack the words to communicate to the family. We are flabbergasted. We don't know how to behave when the family is crying in front of us. And oftentimes, we delegate this to some other member of the family, some other member of our medical team. So, what exactly is bad news? Bad news can be defined as situations where there is either a feeling of no hope, a threat to a person's mental or physical well being, a risk of upsetting an established lifestyle, or where a message is given which conveys to an individual very few choices regarding his or her life. And broadly speaking, bad news is any news that drastically alters a patient's view of his or her future. So it may come as a shock if there is a sudden disclosure of something which is very serious pertaining to the patient. For example, a patient who is told that their test is HIV positive, a son who is told that his father has Alzheimer's disease, a patient who is told that the lump that he was harboring has been diagnosed as cancer, the couple who are told they cannot have children, patients who are admitted with us in severe ARDS, septic shock, multi-organ failure, where we communicate that your loved one is not doing very well and the prognosis is very poor. Or patients who come traumatic, with a severe traumatic brain injury, diffuse axonal injury, and we know they will remain vegetative, and we have to break this news to the family. And also when patient has absent brainstem reflexes. So the condition has deteriorated and now the brainstem functions are absent. So these are some of the examples where, it comes as a great shock to the family when they are disclose this information about their loved ones. So the big question is, are we prepared for this kind of communication? And what exactly is the way we respond? Well, some will embark on a very positive approach. So giving the patient and relatives the hope, which is a false hope, and believing that patient is blissfully ignorant about all this, and he will take whatever we are trying to explain to him. Others will take a middle path, that is, they will explain all the facts to the relatives while keeping the patient in the dark. And few will explain at great length. They will talk about the diagnosis, stage of cancer, options on treatment, side effects of the chemotherapy or other treatment options, financial burden, short and long-term prognosis, and this may upset some families and the patients. Now, India is unique in the sense that compared to the West, where the doctor has to take permission from the patient to disclose it to the family. Here, the family does not want us to disclose bad news to the patient in case the patient is competent, pertaining to, say, cancer or some other serious illness. They don't want to disclose this news to the family, to the patient, thinking that this will lower the morale of the patient and he is blissfully ignorant. He will continue to be so during course of his illness. So, which brings us, to a different situation. We often face this dilemma. Is it ethical that we are disclosing this to the family, but not disclosing it to a competent patient, which is, unethical? We need to understand that there are differential needs of the families, and families who are suddenly bereaved may need more time. Say, for example, the family comes rushing to the hospital because their loved one has been brought from an accident site and they are told that he's having a cardiac arrest. So it is very, very difficult for them to come to terms with reality. The suddenness, the shock of it, doesn't give time to acclimatize or digest this information. So they will need much more support compared to those whose loved ones are already in the ICU and they have seen them deteriorating day by day. So they had time to prepare for the eventuality. And nurses, they feel the junior doctors are the most awkward in handling bereaved relatives because there is no training given to them. And oftentimes they will, in the Indian ICUs, ask the senior nurses to disclose this information. So they do not know how to break bad news, how to talk about death, how to talk about serious situations. So I think this lecture is targeted towards our young doctors and to educate them about the need to learn the grief counseling also. Staff often feels frustrated at inadequate facilities which are available when they are vulnerable, when they are breaking bad news, because the reaction of the family may be sometimes extreme, and you need privacy to break this news, and you need to feel safe that you are disclosing this information, and it may not, family's reaction may not physically harm you. So communication with the families of dying patient is very, very important. And care near the end of life care is an important component in our daily practice. So most deaths will occur these days in ICU after a decision to forego life-sustaining therapies is taken. Concept of patient-centered and family-centered care is gaining ground. More and more ICUs are allowing families to be there with the loved ones who is dying, who is extremely sick, and providing them all kind of religious and cultural support. However, the issues in conscious patients are different. Families in our Indian setup, like I said, request not to tell the patient because he or she will not be able to take the shock. So the issue of confidentiality of the doctor-patient relationships comes into play here. Can we discuss with the relatives without the patient's permission? Should we not fully inform the patient about the disease, complications, outcome, and economic costs? So oftentimes we feel that it is inappropriate and we would rather discuss with the family rather than the patient. Another issue is clinicians focus more on relieving patients' bodily pains and less on the emotional distress and very seldom on their suffering, how the news will affect the patient. So that remains the big question. There has been an age-old paternalistic attitude promoted by Hippocrates long back. He specifically said, concealing most things from the patient while you are attending to him, give necessary orders with cheerfulness and serenity, revealing nothing of the patient's future or present condition. For many patients have taken a turn for the worse by forecast of what is to come. So we have been told time and again that we should take a softer approach to breaking bad news. Do not disclose everything, and keep on showing a ray of hope to the patient. However, in 1847, when you look at the American Medical Association's first code of medical conduct, medical ethics, this was also similar. They said the life of a sick person can be shortened not only by the acts, but also by the words or manner of a physician. It is therefore a sacred duty to guard himself carefully in this respect and to avoid all things which have a tendency to discourage the patient and to depress his spirits. So traditionally, we have been taking a paternalistic attitude, trying to shun away the patient from all the bad news, all the things concerning his future, and talking nicely to him, and communicating that everything is possible and we are doing whatever is best, and he may come out of the crisis. So it's very, very important that we develop a bond with our patient and we communicate what is relevant rather than giving a false ray of hope. But why is it that we find that it's an awkward situation for us and breaking bad news is difficult? Because we feel it's an unpleasant task, because we are talking about things like you may not survive for more than 3 months or 4 months, or your loved one may not survive another 48 hours in the ICU, or despite being on ECMO, he's not going to make it. So these are considered unpleasant tasks where we feel afraid that if they ask specific questions or more pertinent or deeper questions, we may not be able to answer them. Staff are also fearful of the patient's or family's reaction to the news. We are uncertain about how to deal with an intense emotional response. We don't know if somebody, wife or the husband starts crying unconsolably, we don't know what to do. Staff are unprepared for the intensity of breaking bad news. And there is a savior complex that we should also be talking positive things and giving hope until the last. Perspective of death and disability is very, very difficult for us to discuss and to communicate. And talking about these domains needs experience and training. discomfort with negative emotions. So these are some of the things that, we are uncomfortable if somebody's crying, if somebody is, talking to us about why this has deteriorated to such a situation, what was wrong. I brought him or her in time to the hospital. So what was wrong? Was it because of medical reasons, or was it because of incompetence of the staff? So these kind of things that come to mind, and sometimes the families are difficult because they are asking too many questions. So there, when the situation comes that there is something has happened and a bad news has to be broken to the family, we feel completely uncomfortable and we don't want to face it. Most of us do it right most of the time, but things go wrong when we try to escape. We react in anger, we dilute the agenda, and we are far away from truth. We try to escape because we, like I said, we delegate somebody junior or some other person. We try to escape. We don't want to face the family. We tell the residents, you please handle this, you communicate this, and then we walk away. Or distraction. When the family is in grief and we are distracted, maybe we are taking a call on a mobile phone or talking to some other person, or there is somebody who comes and disturbs us, which are not taken lightly by the family because this is a very sad moment for them. Or frontal attack, when we try to justify by attacking the family that you brought him late, you couldn't recognize the symptom, he had a heart attack, you waited until the morning, or he was not able to move his limb and you waited, you didn't know that if you had brought him earlier we could have thrombolized him. So things like that, putting the burden of guilt on the family, resorting to a frontal attack. Intellectualization, where we try to play an intellectual and tell the family that everything is okay, this is what it was supposed to happen, this was the will of the god, and things like that. Or minimization, when we don't want to enter into a prolonged discussion with the family, we want to keep our interaction minimal, we break the bad news and walk away. Or oftentimes when we give empty reassurances, we have seen this happening in COVID when a lot of young people died, husband died or a wife died. So the empty reassurances, when they know for sure that they are going to lose their breadwinners, this is possibly an escapist approach. There are also a lot of barriers which have been identified to delivering bad news. Inadequate time is one. Fears of making a mistake or not showing enough empathy, personal biases and opinions towards the disease. It's not uncommon still in today's time that hospitals do not admit patients who are HIV positive or shun them away to other hospitals. Uneasiness with topic of death and dying. So that is the reason. Lack of support from other members of the healthcare team. Other challenges like language barriers, especially when you are dealing with international patients, or when there are gross cultural differences, or when we have to give prognostic information where the prognosis is extremely poor, and where we have come in contact with the patient for a very short time. Say they were admitted in extremely poor condition, and within no time they have become extremely sick and they are on the verge of death. So we could not develop a bond with the family or the relationship that we want to have with the family. Inadequate time is most important factor because most of the time we are busy seeing the patients, managing the patients, writing files, attending calls, RRTs, code blue. So we rarely have time to spend 15, 20 minutes or 30 minutes with the family, listening to, whatever they have to say and trying to answer them, trying to console them, being with them in this time of crisis. We don't have that time. So that is a major problem. This issue has been discussed in a lot of journals, and the management of bereavement on intensive care units has been highlighted, that all units should allow relatives to be present at the time of death, and they should be allowed to enter and leave ICU freely, and all units should leave them alone with the patient or allow them to see the patient after death if they so wish. And most units allowed religious rituals to be performed. Now, this is part of a survey. 90% units allowed them to help with laying out the body if they wished. In 82% units, nurse was dedicated to caring for grieving relatives. So it was a staff nurse who was looking after the grieving relatives. In 99% of the units, nurse gave information to relatives on administrative requirements following a death. It was spoken advice or written brochure was handed over to them in majority of the cases. And death certificates were available in 45% of the French. This was a French study. 45% of the units during weekend or on bank holiday. So this was a survey that revealed how they were managing. But look at this. Essentially, the nurses are doing this job. So whether it is counseling the family or giving a shoulder to cry on, this is only done by the nurses. 80% of the physicians felt they needed another person to help breaking the news, and generally this was a nurse. GP was informed of the death of their patient in 85% of the cases in France. Only 6% of the critical care staff had received training in breaking bad news. Now, this is very, very important because this will be even lower in India. The figure would be much lower. 82% of the doctors felt that this training would be useful to handle these kind of crises. Now, this was a very important article published in New England Journal of Medicine in 2007, where they talked about a communication strategy and brochure for relatives of patients dying in the ICU and the advantages. So the end-of-life care conference used in the intervention group had 5 objectives for the caregivers: value and appreciate what the family says, acknowledge the family's emotions, listen to the families, understand the patient as a person by asking questions to the family, elicit questions from the family members. So end-of-life care discussions were organized in the study group for 30 minutes versus conventional where they lasted 20 minutes. And brochure on end-of-life care was given in the study group. The results, when they compared with this organized discussion along with a brochure, post-traumatic stress disorder was much less. Hospital anxiety depression scale showed less anxiety and less depression in the relatives where they had gone for organized end-of-life care discussion and had also handed over a brochure. So this is, you can see the HAD score in the 2 randomized group, the intervention group and the control group. So there is a substantial difference here. And both in terms of the anxiety and depression and the stress. Now, next question that comes to mind is, should we prepare for breaking bad news? Of course, it needs preparation. So the ABCDE has been given for this. A is advanced preparation. B is build a therapeutic environment relationship with the family, communicate well, deal with patient and family reactions, encourage and validate emotions. So advanced preparation would mean that we need to assess the patient or the family understanding. We need to know everything about the patient. Preparation is required to answer all the questions, and we need to arrange for a family meeting, practice how we are going to discuss the issue, how we are going to answer the issues. This may not be required when you become senior, but initially, yes, you may need to, like any lecture that you are taking, you need to have any, starting dialogue, and then how this will flow, what information you will give to the family, and how will you convince them. So all that you have to make, a mental framework in your mind. Well, you need to find a quiet place where the family finds some, a place where they can discuss at length with you, they can cry, they can grieve, and they don't feel ashamed about it. And all patient or family fears need to be addressed. So this is very, very important. It essentially says that there has to be a counseling room where you can discuss not only the normal things, but also when you have to break the bad news or you are indulging in end-of-life care decisions. Spikes protocol, I'm sure most postgraduates know about it. It basically is an acronym for setting up the interview, assessing the patient's perception, obtaining the patient's invitation. I have bad news. Are you ready to hear it? Giving knowledge and information to the patient, addressing the patient's emotions with empathic responses, and lastly, the strategy and summary. Communicate well. You need to be direct, avoid euphemisms and medical jargon, talk to them in common terms, common layman's language. Use the words like cancer and death. Allow for silence, ensure patient understanding. Preparation when? Now, physician has to prepare regarding mental and spiritual aspects, consideration of time limitation, revision of information to be communicated. So this is from what we need to do. Read the file, go through the investigations, go through the relevant, the physical and systemic examination, and the ventilator settings and the vasopressor requirements, etc. Preparing patients and their relatives, identify whether patients desires to know the bad news or this has to be delivered. In our system, in the intensive care units, it is most times the family that has to be prepared, so we can inform them that we are going to discuss about their loved one, and we'll be talking about what all is going on, the management part as well as the prognosis part, so that they are prepared and they have the relevant questions in mind. They can gather the family and whoever they feel is important to be during this interview. Preparing the environment. Now we need a room, arrange a suitable emotional, social, and even scientific surrounding, along with building a logical, fundamental relationship with patient and their relatives. Example would be suitable physical conditions, sufficient lighting, comfortable furniture, minimum noise or disturbance, and you need to have water and other things. The patient may, the family may break down, they may cry, they may need to have some water or something. So have some tissue there. Now, arrangement how? Make a prompt appointment with the patient or relatives after breaking bad news, preferably in the following days, to revise the important transferred information, present the information, brochures, supporting resources regarding the illness, answer whatever question the family has, involve patient or the family in decision making pertaining to treatment process, engage patients and their families in supportive and preservative programs to reduce their pain and restrain the disease. Next comes delivering. Now, what? Question is what? Evaluate the family's understanding of the illness and the patient's condition. Deliver the bad news professionally, wisely, and thoughtfully to the relatives through forming an appropriate human and compassionate relationship. You should use simple and clear language without using the technical terms or incomprehensible terms. Take control and manage the consequences and aftershocks of delivering bad news. This is very important. Mentally and emotionally, we should be prepared to encounter a wide range of possible reactions, considering what the relatives believes, their thoughts, their customs, their culture, personalities, their doubts regarding the management, and a whole lot of things. So be prepared for that. You have to deal with the patient's family members, their reaction, and you need to have how they can cope up with this. So that you need to assess, you need to, be prepared. You have to listen actively and show that you are empathic to their, sorrows and the grief. You share their burden of grief. Encourage and validate emotions. Ensure accurate interpretation of the news. Address further needs, including support. Provide written information if required. Arrange a follow-up and process your own feelings. It's very depressing when you are discussing all negativity and about, things not going the right way, patient's condition deteriorating, or, patients almost dying. So you should also, be prepared for that. So there is a balance between the two: understandable, sensitive, informative, supportive, close relative present, versus when you have no time, you are disclosing this in the corridor where you're walking. So you stop for a minute and then discuss, and you are not offering any comfort or any, reply to their questions or queries. So when we follow this kind of an organized approach, studies have shown that we can develop an effective program. So now, what are the components? We understand patients' experience. They need how they have coped up with the existing services. Is there any suggestion for change? Then we analyze why the patients and their families had poor responses to these situations. We can improve the services, we can implement the improved design, and then we can further evaluate. So this is also a very important quality initiative. And the idea is we redesign healthcare delivery from the patient's perspective. So lastly, to conclude, we need to be trained. The ICU staff need to be trained. We need to understand that family is emotional. There will be emotional outbursts, so we need to be, able to contain the situation, cope up with that family's outburst. Proactive strategy based on ABCD approach is better. So organized approach is better than unconventional approach. And consider the need for creating brochures on the subject, because then the family comes prepared if they have read the brochure. Thank you very much for listening to this video. I hope this makes breaking bad news a little more easy on you, but it will still require a lot of practice. Thank you very much for your time.